Good evening, everyone. My name is Jim Douketis. It's my pleasure on behalf of the faculty and Thrombosis Canada to welcome you to this evening's webinar on COVID-19 patient management, insights, treatments, and challenges. This is our 7th or 8th iteration that we've done on this topic over the past year. And of course, we all know how the pandemic has evolved, how the patient landscape has evolved, and how the treatments have evolved. And the objective today is to make sure that you're up to date on this. Next slide. Now you're probably wondering why COVID-19 and Thrombosis Canada. Well, although we are specialists in thrombosis, all of us are involved in the care of patients with COVID-19. Myself, Dr. Castellucci, Dr. Benjamin Bell are internists involved in inpatient care of COVID-19 patients. We have Dr. Alan Bell and Lauren Cameron, who are primary care physicians, and Dr. Eddy Lang, who is an emergency room physician. And we're welcoming tonight as well Dr. Dominik Mertz, an infectious disease specialist. So we provide you hopefully a multidisciplinary perspective of the COVID-19 infection from a variety of perspectives tonight. Next slide. This is my disclosure, as you can see, and next slide. In terms of the program, we have the following support from Pfizer Hospital in the form of an unrestricted educational grant. The program itself has received no in-kind support. Next slide. We take very seriously the issue of mitigating potential bias, and at the end we will ask you about this as well as part of the evaluation of this program. If you feel that there is any form of bias, please feel free to notify about this. Next slide. And this program is accredited as a group learning program by the College of Family Physicians of Ontario and the Ontario chapter for up to 1.5 Main Pro Plus credits. Tonight's learning objectives are as follows. So at the end of the evening tonight, we want you to have an opportunity to ask questions, provide insights into the chat line, and I'll try to monitor these and we'll discuss them at the end of the program. But at the end, what we want is for you to be able to understand new developments and guidance on the management of patients with COVID-19. And again, share your insights about how to manage these patients and some of your challenges that you have faced, as well as some of the key elements that bring to the fore the management of these patients after hospitalization. Next slide. And the agenda, as you will see, by our faculty will kind of traverse the journey of the patient with COVID-19, starting in a family practice or primary care setting, reflecting the perspective of Dr. Bell, a family physician, Dr. Mertz, an infectious disease specialist, and then moving to the emergency department with Dr. Eddy Lang, to the in-hospital setting with Dr. Benjamin Bell and Lana Castellucci. And you'll see that what's conspicuously absent is we're not focusing on the ICU population as much, because as we know, most of the patient care for COVID-19 is primarily in the outpatient setting and to some degree also in the inpatient setting. So with that, I'm going to hand it over to Dr. Alan Bell, Assistant Professor of Family Medicine at the University of Toronto. And Alan, the floor is yours.
Well, thanks very much, Jim. It's a pleasure to be here this evening. These are my disclosures. Next slide, please. So I'm a family doc, and that's what I do. I'm in the trenches seeing family medicine, and I'm hoping that my presentation is going to assist my family medicine colleagues in managing what is still a very common presentation in family practice. We're seeing plenty of it with the current wave, that's for sure. So why don't we just start right out with a case. This is a patient of mine. His name is Chuck. He's a 67-year-old auto mechanic who presents with fever, productive cough, headache, myalgia of about 3 days duration. He's not short of breath. He has no chest pain. He has no GI symptoms. He lives with his wife and one adult daughter. All are fully vaccinated, plus 1 booster, 3 shots. And he tested on a PCR 1 day prior to presentation positive. He's comorbid with hypertension, hyperlipidemia, obesity, and 20-pack year history of smoking under his belt. He's taking an ACE inhibitor diuretic combination for his blood pressure and a statin for his hyperlipidemia. Next slide, please. So what are the considerations that we all in family medicine should have for this patient? Well, I think these days we have to be thinking very much about isolation strategy, not only for the patient, but also for the household contacts, as well as casual asymptomatic contacts. Perhaps we should think about some further investigations that may be appropriate for the patient, how to monitor this patient, and whether we need to follow up or when the follow-up should be. We also, of course, have to think about treatment options. And I think the treatment options that we're seeing these days are really mostly in the family practice world. And we're going to be thinking about anti-inflammatory treatments, as well as antivirals. Now, as I'm going to be talking about outpatient care, my anti-inflammatory discussion will not be including the IL-6 or JAK inhibitors, which are reserved for sick inpatients. And in terms of antivirals, I think it's very much important for us to be thinking about the role of nirmatrelvir, ritonavir, and I'm going to refer to that this evening as Paxlovid. I'm going to be using the trade name. I apologize for that, but the generic's a bit of a mouthful. Sorry. And I think primary care has to be also thinking very much about the role of remdesivir. There is another antiviral that has not yet been licensed in Canada. It's not clear if it's going to be. So we're not going to be discussing that. Next slide, please. So in terms of isolation strategy, what I'm going to be giving you here is Ontario jurisdiction information. In fact, more specifically, based on the Toronto Public Health recommendations, which I think can be applicable widely, but are very different by jurisdiction. I'm currently in the UK, and there is nobody thinking about this at all. But in Ontario, I think it's very sensible to be following this guidance. So fully vaccinated individuals who are positive, our patient Chuck, should be advised to self-isolate for 5 days from symptom onset or from the date of his tests. Other patients who are not fully vaccinated, who have received 1 shot or no shots, or patients who are immunocompromised, or patients who have been hospitalized in a non-ICU setting, are advised to isolate for 10 days. Sicker patients carry larger viral loads. Immunocompromised patients carry larger viral loads and need to isolate a little bit longer. Patients with severe illness, somebody who's been in the ICU, there's 20 days of isolation that is required, but typically that isolation is going to occur in hospital for these patients. What about household contacts? The general rule is that household contacts should isolate for the same duration as the case. However, if these household contacts are asymptomatic and have any one of the following criteria, that is that they've had a prior positive test within the last 90 days, so they've had a recent infection, as well as being asymptomatic, or if they've been, if they're over 18 and they've had 3 doses, or 4 if they're immunocompromised, or if they're under 18 and they've had 2 doses of vaccine. So these patients are not likely to get or transmit the illness, and there is no requirement for them to self-isolate. However, they of course need to continue to monitor for symptoms and stay away from high-risk environments, nursing homes, the elderly, the frail individuals, and of course to wear a mask. And individuals, if they're immunocompromised and have none of the above criteria, 10 days of self-isolation is required if they've got a household contact. So it can actually be longer for these individuals than for the case itself. In terms of casual, non-household, asymptomatic contacts, and that's defined as somebody who've been within 6 feet for at least 15 minutes with no mask with an individual. These individuals do not need to self-isolate unless they become symptomatic. But of course, the same comment about the household contacts, they should monitor for 10 days, they should mask, and they should avoid high-risk settings. Next slide, please. Now, what about treatment? So as I've said, a lot of the treatment for COVID these days is outpatient treatment. So thank goodness for vaccination. Our patients aren't getting as sick, aren't requiring as much hospitalization, and very much the treatment is falling into the hands of family doctors. Now, this is the current recommendations from the COVID-19 science table, and you'll see that the recommendations vary very much depending on patient characteristics. And what this is based on is whether or not the patient has a greater than or less than 5% risk of hospitalization from the available data. So you'll see that the key parameters that need to be considered here for whether or not a patient is considered above or below that 5%, which is going to determine whether or not that patient should receive an antiviral in the form of Paxlovid or ritonavir or remdesivir, is going to depend on their vaccination status, which you see across the top, their age, which you see on the vertical column, as well as whether or not they are immunocompromised, and on the far right side, their risk factors. So generally speaking, individuals who are under the age of 70 and have had 3 doses of vaccine and are not pregnant or immunocompromised are generally at standard risk and do not require antiviral treatment. Individuals who have had 0 doses generally are all considered to be at elevated risk, depending on their additional risk factors. So even a 20-year-old who has got 3 risk factors, such as the ones listed on the right side, such as obesity, diabetes, heart disease, hypertension, heart failure, chronic respiratory disease, intellectual disability, sickle cell disease, moderate kidney disease, EGFR under 60, moderate or severe liver disease. If they've got 3 and they're under 20, they are candidates for treatment with an antiviral. If they are over 70, they don't require any of those risk factors. You can refer to this table at the Ontario Science Table website. It's available for you. I think that we should all have this posted in our offices or wherever we're currently practicing to determine very quickly who requires treatment. So I'm not going to go through the rest, but you see that immunocompromised individuals are considered to be at a greater than 5% risk regardless of their vaccine status, and all should, or age, and all of them should be offered antiviral treatment. Pregnant patients, if they've had 3 doses or even 1 or 2 doses, remain at standard risk because of their young age for the most part. It's only the high-risk patients who have not been vaccinated and are pregnant who are considered for antiviral therapy. Next slide, please. And here are the treatments that we can offer. So there are 2 antiviral treatments that I mentioned earlier. There is Paxlovid or remdesivir. The, of course, obvious advantage of Paxlovid is that it is an oral medication. It's dosed as 300 milligrams of nirmatrelvir and 150 milligrams of ritonavir. That is very nicely compliance packaged for the patients to take 2 of the nirmatrelvir pills and 1 of the ritonavir pills twice daily for a period of 5 days. It's important to remember that patients should be presenting, if you're going to start them on this drug, it needs to be started within the first 5 days following symptom onset. Now, there are patients who can't take Paxlovid, and we'll get into that a little bit more as this presentation goes, but the key issues around it are drug interactions or advanced renal failure. This drug has got a great deal of interactions. You should be aware that ritonavir is put into this drug combination not as an antiviral agent. It is put in there as a CYP3A4 inhibitor that simply increases the duration and strength that we can get out of the nirmatrelvir. So being probably the most potent currently marketed medication as an inhibitor of 3A4, it's got a lot of drug interactions, including many of the drugs that we use every day, and relevant to Thrombosis Canada, all of the direct-acting oral anticoagulants. So there are many patients who can't take it due to drug interaction issues or advanced renal failure. I should also mention that there is a reduced renal function dose where we half the dose of the nirmatrelvir component of the drug, and the manufacturer does offer a renal packaging for these patients as well, and you should be aware of that. Patients who can't take it are going to require remdesivir, which is an intravenous drug. It should be given within 7 days of symptom onset. They require an IV dose on day 1, and then a half that dose for the following 2 days. a lot more complicated, a lot more difficult, but mostly it's going to be available by referring these patients to a local COVID treatment center where remdesivir infusions are available. Now, you may also consider other medications that can be given to these patients, but mostly we'll talk about fluvoxamine and budesonide as for patients who are considered to be at high risk, but not qualifying for specific antiviral therapy. And these are patients at standard risk who can receive budesonide 800 micrograms inhaled twice daily for 14 days. And I'll talk a little bit more about the data supporting that. Fluvoxamine is another option. It's odd that an antidepressant should be appropriate for the treatment of COVID-19. However, you are also going to see data supporting the use of that drug, but you also should be aware of the very common drug interactions and other side effects that are associated with it, and the drug needs to be titrated up according to the schedule that I've got here, which is starting at 50 milligrams daily and up titrating to 100 milligrams twice a day for a total of 15 days. Definitely a secondary option when budesonide is around, in my view. Next slide, please. I think we've got some forward-thinking provinces here, particularly Quebec, Alberta, and Saskatchewan, as well as Newfoundland and Labrador, where pharmacists are able to screen and prescribe this medication to get it into them quickly. I think that is a very positive attitude. We're seeing more and more role for pharmacists in prescribing medications with a clear role, and I congratulate those provinces and hope the rest of the country will follow suit. Next slide, please. Right. So what if your patient is on a DOAC? We are Thrombosis Canada. We should be discussing this. So I thought I would just quickly mention to you that if your patients are taking a direct-acting oral anticoagulant, many of them are elderly, particularly the ones that we're treating for atrial fibrillation and may qualify for antiviral therapy. As I mentioned, ritonavir is a very potent 3A4 inhibitor and has the potential to significantly raise the blood levels of these anticoagulants, resulting in significant bleeding. So there are differences. The rivaroxaban is much more sensitive to this effect, and if a patient is taking rivaroxaban, that we need to be a little bit more aggressive in terms of not giving that in combination with Paxlovid. The first question that needs to be asked with any patient who is on a DOAC, is this patient appropriate for remdesivir? Are we able to get the remdesivir infusion into this patient? And if the answer is yes, it should be given to them instead of Paxlovid. So going down a little bit further, I don't want to get into too much detail on this, but if the patient is on rivaroxaban, we have to ask why they are taking it. In other words, what is their risk? How necessary is this drug? And if they're taking it for atrial fibrillation, a few days off the drug represents a relatively small day-to-day risk, and it can be substituted with edoxaban at a lower dose. If the patient is taking it for venous thromboembolism, either a DVT or a pulmonary embolus, we have to ask how high is their risk, and if they are at high risk, the rivaroxaban should be stopped and replaced with a low molecular weight heparin. If they are taking it for a lower risk, it can be replaced with aspirin. Now, let's go to the other side. And if the patient is taking apixaban, dabigatran, or edoxaban, if they are already on the lower dose of these drugs, so 2.5 twice a day in the case of apixaban, 110 in the case of dabigatran, or 30 milligrams daily in the case of edoxaban, these patients can stay on the dose without change. However, if they are not on the low dose, once again, we have to ask why are they taking it. If it's for atrial fibrillation, they should be reduced to the half dose. If they are taking it for venous thromboembolism, once again, we'll follow the same algorithm as we did with rivaroxaban and substitute either low molecular weight heparin or aspirin, depending on their risk. Next slide, please. And you'll be happy to know that I'm not going to go through the details of this slide, which tells you how to make those shifts, either low molecular weight heparin, aspirin, or the alternative dosing or type of direct-acting oral anticoagulant. But these are all available on the Ontario Science Table website. if you have to do it, go there, look for it. It's easy to find. You can click on what if your patient is on a DOAC and needs Paxlovid. Very simple to find on that site. And it's also available, I understand, on the Thrombosis Canada website. Next slide, please. In terms of adverse events, if you're giving, other than the drug interactions that I just discussed, if you're giving Paxlovid, it's a relatively well-tolerated drug. About 5 or 6% will complain of taste disturbance, this dysgeusia symptom. Beyond that, you might see a little bit of diarrhea, and that's pretty much it. Next slide, please. Not recommended at the present time for the management of COVID-19 are colchicine, interferon, and vitamin D, although there is some reasonable data based on the Corona trial that colchicine may be of some value, but currently not recommended in Ontario anyways. And again, these recommendations are jurisdiction dependent, but very specifically treatments that we should not be using at this time, specifically recommended against because of lack of efficacy and increased risk of side effects include any antibiotic, any of the previously available neutralizing antibodies, which are no longer available against the current strains of COVID-19, certainly hydroxychloroquine or chloroquine, ivermectin, or lopinavir or ritonavir currently have no effect against this virus. Next slide, please. So what about monitoring and follow-up? Well, I think the single most important thing to ensure that you do with your patients who are presented with COVID-19 is make sure they don't stay home and get sicker and sicker and die. And I've actually experienced a patient of mine having that. Right, so ensure that they're not experiencing shortness of breath, persistent vomiting and diarrhea, or severe GI symptoms where they're unable to maintain fluids if they're syncopal or having pre-syncope. Reduced urine output are things that you should advise your patients to watch for if they're having GI symptoms. I like to provide my sicker patients with a home pulse oximeter. I'm fortunate enough to have been supplied by a few of these that I do give to patients who I'm concerned about, history of COPD, other comorbidities, or patients perhaps that I'm treating, and an O2 level, an O2 sat of less than 92% should be a trigger to send these patients to hospital. Usually I don't require any additional investigations. The other thing I may consider would be a chest x-ray in the patient who I suspect has pneumonia, although typically it's not going to alter treatment all that much, even if they do have some degree of consolidation. I will often follow them up in a week just to ensure that, that they're not getting sicker. Next slide, please. Few words about budesonide. It's been studied in a number of trials. I just want to show you the principal study, which was specifically aimed at looking at budesonide against a couple of other treatments in terms of reducing severity of illness, requirements for hospitalization, and duration of illness. Patients could be unwell for up to 14 days before being randomized into this trial with a positive test. Next slide, please, but not admitted to hospital. Next slide, please. So 4,700 participants got budesonide, usual care, or various other treatments. Next slide. And what we saw was a 3-day reduction in the duration of illness that was highly statistically significant, and a 2% absolute reduction, number needed to treat, of approximately 50 for hospitalization or death. But I will point out that this did not reach statistical significance, but the authors did do a probability of superiority calculation and determined that there was a 96% probability that this effect is real, despite the fact that the confidence interval crossed 1 to 1.03. Next slide, please. Gleasonide can also be used as an inhaled steroid if budesonide is not available, and there is trial data to support it. Next slide, please. Right, so we're returning back to Chuck. Chuck was educated about watching for red flag symptoms. He was advised to self-isolate for 5 days along with his household contacts, and he was treated with budesonide 800 micrograms twice daily for 14 days. Now, with that, I will turn it over to my infectious disease colleague, Dominik Mertz, to take a slightly deeper dive into the management of these patients. Thank you.
Yeah, thanks, Alan, for the great summary. And what I will do is to provide you with some more background information on as to why the recommendations are what they are at this point of time. Next slide, please. And on next one. My disclosures. You've already seen this here from the Ontario Science Table, as Alan mentioned, depending on number of risk factors, age, and number of vaccine doses, you're either considered standard risk, which means no additional treatment required, versus high risk when you have the indication for Paxlovid, for example, or remdesivir. Next slide. As also mentioned by Alan previously, it's based on a roughly 5% risk of hospital admission if remained untreated. And this is from BC, actually, this data. And you can see that with 0 risk factors, you have to have 0 doses and be older than 70 to get across that threshold. While if you have 3 and more risk factors, as Alan mentioned, even if you're less than 20 and you haven't seen a vaccine yet, you would qualify for testing, for treatment. Now, all of this being said, we are showing you the Ontario Science Table recommendation. The Ontario provincial recommendations are a little bit more lenient. And later on, we will also hear about the current situation in Alberta in terms of recommendations. So it's not black or white. And the reason why I will come to in one of my next slides. Next one. The one prior, you still had Sotrovimab listed. That was before BA2, so the recommendation up to January, or the January wave. Then with BA2 coming up, Sotrovimab disappeared, and we are down to Paxlovid, remdesivir, Fluvoxamine. These are the 3 treatment options that I will talk about. Budesonide, you've already heard about. These are the current recommendations for the outpatient management. Next slide. So what about Sotrovimab? In principle, it worked very well, including BA1 here based on pre-BA1 or pre-Omicron data, though we have had an 80% adjusted relative risk reduction in all-cause hospitalization with treatment with Sotrovimab. Then unfortunately BA2 and now currently BA4 and 5 that behave similarly happened, and we've lost the treatment. Next slide shows you one of those in vitro studies which showed basically a hit by the factor of 50 sort of against the activity of Sotrovimab, and that's why it had been recommended against ever since BA2 took over. And as I mentioned, BA4 and BA5 are in a similar ballpark. Next slide. So Sotrovimab is out of the equation. Remdesivir, as already mentioned by Alan, absolutely still an option, has the downside of being an IV treatment. This here is the actual data that resulted in that recommendation. These are, again, mild outpatient with mild disease, primary outcome being COVID-19 related hospitalization or death up to day 28. And you can see here that the hazard ratio was reduced by a factor of almost 90.9, so 90%. Which is quite impressive and certainly reflected by what we've seen in practice as well. Next slide. So in summary, as already mentioned, it's an IV infusion, so you need to have an outpatient clinic set up and the referral process to that clinic. The data supports, and that's a general challenge that we have, supports a benefit in the non-immune population. So all those trials, including most of the Paxlovid data that I'm going to show you, has been conducted prior to having a largely vaccinated population. So what we are currently doing, we are generalizing from that non-immune population to a at least partially immune population, and sort of assume that if you are still relatively high risk, despite your immune status, you may still benefit from the treatment. And that resulted in that arbitrary but threshold of 5% or more, which we are currently recommending. The time window with remdesivir is up to 7 days from onset of symptoms, so 2 days longer than the time that you have for Paxlovid. Next slide. Molnupiravir, just the one slide here, hasn't been approved in Canada yet. It's being used in some countries, including the UK. Has shown a relative risk reduction in the outcome of progression similar to the previous data with remdesivir, primarily defined by need for hospitalization. 50% at the interim analysis, eventually it was a 30% risk reduction. Hard to explain as to why the risk dropped, the relative risk reduction dropped, but also the risk in the placebo group, which was 14% in the interim analysis and then only 9.7% in the final analysis. So there must have been changes in the population over time, which then resulted in a lower relative risk reduction. But as I mentioned, not available in Canada. As such, we move on to the next slide, which brings us to the topic of Paxlovid, where I will spend most of the time on, and we as a group will spend most of the time on with, because that's a treatment that's available to you, which covers the vast majority of the COVID patient we see nowadays, which, as it had been mentioned, is typically the outpatient population at this point of time. This is the EPIC-HR trial, so the first data that had been first shared in a media release and later on published earlier this year in the New England Journal of Medicine for high-risk individuals. So high risk in terms of risk of progression of mild to moderate and severe disease if infected with COVID. So these are entirely unvaccinated patients in this cohort. Important to mention because I will show you the data of the standard risk trial on the next slide. And what you can see here on the right-hand side is that in every subgroup that they did analysis on, there was a benefit with treatment with Paxlovid. The only exception being if they received COVID-19 monoclonal antibody treatment at the same time. So it should be either or. But again, the monoclonal antibody is no longer an option with BA4 and 5, and as such, we don't see that subgroup anymore. In summary, in the unvaccinated patient population at high risk for progression, so multiple risk factors, we've seen an 89% relative risk reduction in hospital admissions or death, and also a 10-fold decrease in viral load, which may reduce the risk of transmission. At least that's the hope there. Next slide. Now, the EPIC standard risk trial is similar to the high-risk trial. The data had been first shared, or at this point only been shared by media release. And this is from the Pfizer website, what you can see here. So they state that the self-reported sustained elevation of all symptoms for 4 consecutive days, which was the primary endpoint, was not met. So no statistically significant difference for that primary outcome. There's several secondary outcomes, which all were not, or not all were statistically significant, to frame it that way, but are supportive of the data in the higher risk population. So in general, in favor of Paxlovid. One of the pre-specified secondary endpoints was COVID-19 related medical visits, which was one of the outcomes where they did see a significant reduction of 62%. There was a non-significant 57% reduction in hospitalizations and death. Now, why are all those analyses non-statistically significant, despite a quite significant effect size when you look at the estimates here? Basically because the very low rate of hospitalization or death in this standard risk population. Standard risk population, I forgot to mention, are either vaccinated individuals with multiple risk factors or unvaccinated individuals with only one risk factor. So in summary, in standard risk patients, similar non-significant reduction in the secondary outcome of hospitalization or death in the non-vaccinated and the vaccinated. The non-vaccinated subgroup, it was 0.8%. In the vaccinated, it was 1.9% risk. And a significant 62% decrease in COVID-related medical visits. But importantly to mention, that was only one of several secondary endpoints that they have had. Next slide. And again, we are waiting at this point for the scientific publication, which may provide us with a little bit more information, because at this point we are sort of lost in terms of, okay, where should we draw the line in the sand? Who clearly benefits from Paxlovid and who doesn't? One other study, which, well, not published yet, it's a preprint from a little bit more than a week ago. I just see the citation at the bottom is wrong, but you can see on the upper left side what the study is from Hong Kong by Leung and Cowling's group. A difficult study design. So basically it's a matched cohort with then, as a secondary analysis, a nested match case control study. I'm only showing you the cohort study, and they only focus on the comparison of Paxlovid, so nirmatrelvir and ritonavir versus control. You can see on average this patient population was 70 years old, relatively low Charlson's index, so low number of comorbidities, not a severely sick population, and 1/3 fully vaccinated. Important to mention, many were vaccinated with the Chinese vaccine, which most likely is inferior to our mRNA vaccines. A small subset of this patient population was vaccinated with an mRNA vaccine. Next slide. And that's what they found. So all-cause mortality, a 75% reduction in the hazard with treatment with Paxlovid versus control. For hospitalization, a also significant reduction of 31%. So somewhere between what we've seen in the EPIC high risk and the EPIC standard risk trials. One issue when you're looking at the survival analysis here is that you already see a significant difference between the two curves on day one, but on average treatment only started on day 2. So there must be some confounding happening here as well, with the non-treated patient population probably having some other non-controlled factors that resulted in a higher risk for hospitalization in them compared to those who had been treated as Paxlovid. So again, it doesn't give us the final answer how effective Paxlovid actually is in that sort of standard risk population, unfortunately. Next slide. There's other studies that are ongoing, including a trial in the UK, which hopefully will help us moving forward. In summary, Paxlovid approved for use in Canada since mid-January. We have a time window of 5 days from onset of symptoms. As Alan already mentioned, BID course for 5 days. Next slide. I mentioned that I will quickly touch on fluvoxamine as well, off-label use of this drug, of course. The most important trial here was the Together trial, published October 2021. In this cohort of patients, there was a small minority that was vaccinated. The treatment that they used in the trial was 100 milligrams BID for 10 days, started within 7 days of symptom onset. As Alan mentioned, the recommendation is to not go to the full dose immediately because of the side effects. However, what they found here is a 31% relative risk reduction with fluvoxamine over placebo in their primary outcome, which was hospitalization or requirement to be seen in an emergency care setting for their COVID-19 symptoms. Next slide. There's also a systematic review out there in preprint at this point as well, 25% relative risk reduction here, similar to the Together trial, which was driving most of the effect that had been seen. And you can see there were two smaller studies as well, which in general were in favor of treatment as well. So absolutely another option that we have in particular in the primary care setting. Next slide. Next slide. Here we go. Caveats, as already mentioned by Alan as well. Again, interactions, including serotonin syndrome with MAO inhibitors. Consider the phase-in, start off with 50 milligrams once daily, then increase to either 50 or 100 milligrams BID, depending on how well patients tolerated the treatment. Duration somewhere between 10 and 15 days. The COVID table recommends 15 days. In the trial, it was 10 days. Next slide. And this has already been mentioned as well. We need to make sure that we sort of look at some of those drugs in a different way, some of which are either have some promising data but not recommended yet, as such as colchicine and interferon. And then we have drugs that we would only use for moderate to severe disease, dexamethasone, Tosalismab, and we will talk about those later on for patients who require hospital admissions. And then there's those on the right-hand side that Alan already mentioned, which are unproven in any setting, whether it's mild disease, moderate disease, as an outpatient or as an inpatient. And I think at this point, I will hand over. That was my last slide. Thank you very much. Over to you, Eddie.
Thank you, Dominik. It's my pleasure to be part of this presentation tonight. I'm going to provide you with an overview of the emergency department management of COVID in this particular phase of the pandemic. My disclosures on the previous slide are that I've chosen to direct all industry-sourced funding and honoraria to 2 research funds that help support our trainees. So the specific topics I want to weigh in on is what's happening with COVID in our emergency departments. What are the key issues that we're facing? Emergency departments have been in the news a great deal because of the amount of stress that we're under. We are the canary in the coal mine, the safety net of the healthcare system, and a lot of the problems that we're seeing right now relate to staffing issues, but oddly enough are not really directly related to COVID patients coming through our door. Our overall numbers haven't increased, nor have, at least as of yet, we've been seeing a significant increase in COVID patients or all patients requiring admission. And then I'm going to focus on what are the key treatment decisions that we're facing right now. Next slide. So where are we in this pandemic? This is, I think, a telling slide from a few days ago in Alberta. What I want to draw your attention to is the orange curve talks about our non-ICU hospitalizations in the whole province, and our pink is the ICU. So what is, I think, clear is that we are in a bit of a plateau, and unfortunately, I believe this is most likely the beginning of the next BA5 driven wave. Just data coming out today shows that our positivity rate is climbing again, our admission rate, and even our deaths are climbing again, unfortunately. This is not, as of yet, translated into a strain on ICU beds, and I think that is something that a lot of us are appreciating, that the severe hypoxic respiratory failure that was leading us to intubate many patients in the Delta wave is not currently happening. The other thing I think is important to point out is that of all of the admissions coming in with COVID, at least half are not what we would say is directly due to COVID pneumonia. They're either incidentally discovered being COVID positive as a result of minor symptoms in a patient with appendicitis, for example, or patients who are elderly, frail, and have deteriorated or fallen as a result of the flu-like illness that is often seen with COVID. Where are we going in the future? One of the things we're watching is the wastewater analysis. Next slide. And this is the most recent data we have here in Alberta. And unfortunately, as you can see, just from a few days ago, we look to be on another uptick. This is a early marker of what is yet to come, and usually the wastewater analysis and COVID concentrations precedes hospitalizations by about a week or two. So we're all bracing for what we can anticipate later this summer. So let me present a case to you. Next slide. But before I do that, let me make the key point. Although we've been discussing therapeutics and how to manage the COVID patient who's in front of you, this is a really important analysis, I think, that just came out of the Lancet, showing that really the most, I think, dramatic story of the pandemic has been the incredible impact of vaccines. And in this, I think, fairly robust analysis, more than 20 million lives have been averted due to vaccination. That's, of course, nearly triple or more than triple of what we've lost so far to the pandemic. So as much as we're talking about the acute management, reinforcing the importance of vaccination and boosters is still highly relevant at this stage of the pandemic. And that not only means averting deaths and hospitalizations, but also, I think, convincing evidence that long COVID and disability and the severity of the illness will be affected if people are not only vaccinated, but boosted and double boosted. Next slide. So here's our patient, 67-year-old male coming to the emergency department, has a history of COPD, attended a small gathering 7 days ago, and is now coming to you with sore throat. This is a somewhat uncommon presentation, but there is some worsening of shortness of breath on exertion for the past 3 days. Now, this person decided not to get an additional vaccination, not uncommon in Canada and in Alberta, but still chose to find out if this was COVID or not. The family really wanted to know. And in the first rapid antigen test, which is the primary way that most people are being tested right now, this came back as negative. And I think that's an important point to emphasize here. There's a fairly strong false negative rate in rapid antigen testing in the first days of symptoms, leading to some difficulties in making the diagnosis and making some of the tighter timelines around eligibility for some of the medications that we've been discussing so far. And people are reporting up to 5 or 6 days of symptoms before their rapid test goes positive, especially in some of those who've been vaccinated, perhaps representing a lower viral load. However, this morning, Mr. D was positive. He appears generally well. He's come to get treatment advice. He's not able to get through to primary care today. And he is generally well, but his saturations do dip with exertion. So does this patient need to come into the hospital? Next slide. What we've seen over the last several months is almost a cottage industry in risk stratification scores. And I present one to you here that's based on some of the most important predictors, which is room air saturation, obesity, which was an important driver of respiratory failure, age, of course, and respiratory rate, and underlying morbidity from previous other illnesses, such as stroke. But in essence, these have essentially fallen out of favor. They're less applicable in BA5, and really we generally base our decisions on more general questions of whether they can function at home. And on the rare occasion that we do see a BA5 patient with a COVID pneumonia, their oxygen requirements will usually dictate whether they need to come into the hospital. But this patient is well enough to go home. Our key decision actually now is, should we initiate Paxlovid at this point? So next slide. This is from our guidance here in Alberta. Depending on how many doses I've received, you've seen something similar from our other speakers. This one's maybe a bit more simple and straightforward. And because our threshold is to have only one pre-existing condition, 2 doses of vaccination, being over 60, this patient would qualify. And we have some fairly sophisticated methods in place in Alberta. We have a 1-800 number where you would be connected to a Paxlovid physician who would arrange the medication to be prescribed if you're not getting it directly at a pharmacy. We also have leveraged our EMS units to go into your home and administer remdesivir if that's appropriate for you as well. Although I have a feeling that these treatments are falling out of favor, A, because it's difficult to make the diagnosis within the necessary time window, and B, to be frank, people who have avoided vaccinations are not generally ones that are running to see healthcare when they develop mild flu-like symptoms, and hence we are missing the under-vaccinated or partially vaccinated because they are often not being identified due to the paucity of PCR testing and the general distrust of medical care around COVID treatment. So next slide. One of the things I want to emphasize is that this is a rapidly moving target. Guidelines around the world are not always on the same page on this. There is, however, a really phenomenal resource that's led from Canada, which takes you around the world and looks at how COVID care is recommended around a wide range of interventions, from vaccination to PPE to antivirals. And if you were to do a search for Paxlovid in this search engine, you would find some interesting results. So for example, the search will come up with this grid here showing you how many of the 3,000 recommendations from various guidelines around the world will fall into these various categories. So there's it's an incredibly rich database that you can interrogate for free. When it comes to Paxlovid specifically, next slide, what we see is that the National Institute of Clinical Excellence, which we often turn to for high trustworthy guidelines, you can see the agree to score here, showing that it is quite reliable. They've come out with the analysis of the EPIC trial to constitute low certainty in evidence. That's probably because of the evolution of the BA virus and the limits to applicability around the current wave, and including the side effects that were noted. If you go to the next slide, you'll find a much more rigorous and strong positive recommendation, raising the grade of certainty around the Paxlovid evidence to moderate. And the NIH in the US is now taking the same data and now making this a strong recommendation in contrast to our colleagues across the pond in the UK. So next slide. But of course, this is supported and as it is by the Ontario Science Table. If you wanted to look out west, the BC COVID Therapeutic Committee also endorses the molecules that you've heard about, including Fluvoxamine and inhaled corticosteroids, as well as Paxlovid for the appropriately eligible patient. Next slide. Just want to leave you with another resource that you might want to use. There's a downloadable app, interaction checker, that can facilitate the safe prescribing of Paxlovid in patients who are on concomitant medications. COVID-19 druginteractions.org is where you would find that. Next slide. This is an algorithm that will really emphasize the importance of early and repeat testing. If you have a high index of suspicion, a single test is very likely to be negative, especially early on, and to identify those patients likely to benefit, although the number needed to treat to prevent a hospitalization is likely far lower now than it was in the EPIC body of research. This is the pathway that you would follow. Finally, next slide. I just want to leave you with some resources. Feel free to visit our Alberta Health Services site. You'll find a wealth of information, including frequently asked questions, both for providers and for patients, that can help guide all of these complex management decisions. Thank you very much. One thing, unfortunately, though, that happened to this patient, despite our best efforts, is that he came back with worsening saturations and had to be admitted to hospital. So I will pass the baton to Dr. Bell, who's going to speak about inpatient management. Thank you.
Thanks very much, Eddie. My name is Ben. I'm going to talk about what we do for hospitalized inpatients. I'll just start, though, by saying the nature of COVID has changed dramatically over the course of the pandemic. At first, when we were dealing with a highly contagious virus with really no exposure in the human population, we were seeing a lot of patients who were severely ill, particularly when the Delta strain was around pre-vaccination. In that context, we were dealing with a lot of COVID pneumonia patients, and that's really what this section of the presentation focuses on. But because there's been so much natural immunity from exposure and vaccination, we're seeing that type of presentation much less frequently now. So I'm going to go through these slides fairly quickly because I think perhaps it's somewhat less relevant in today's context compared to the outpatient treatment and vaccination than it was perhaps even 6, 8, 12 months ago. These are my disclosures. Next slide, please. So similar to the outpatient management, when we think about COVID therapeutics generally, we think about the immune response, and we think about inhibiting the virus from replicating directly. And so inpatient therapeutics similarly focus on those two pillars. Typically when patients are hospitalized, though, they're further on in their illness course. So you'll note that the majority of the inpatient therapeutics really are focused on immune suppression with a little bit of antiviral medication in there, being the remdesivir. Next slide, please. It became evident very early on in the pandemic that the immune response to COVID-19, particularly in a host who has not been exposed to the virus before, was a huge part of the illness itself rather than just the virus itself. And so very early on in the pandemic, when that was recognized, easy, cheap immune suppressants were looked at, steroids. And so dexamethasone, which is widely available, inexpensive, generic, available orally or IV, was investigated. And what was found very quickly was that when you gave dexamethasone to patients with confirmed COVID-19 infection, that you saved lives, you prevented people from moving to the ICU, but that was only true if individuals were requiring oxygen. So you'll note that the row there that says no oxygen received, dexamethasone actually, fared worse in those patients with numerically more deaths. So we do not use dexamethasone in COVID-19 patients unless they are on oxygen, and it's felt that their oxygen dependence is related to COVID-19 pneumonia. Next slide, please. So, just the salient details, there's mortality benefit for ICU patients, and you get people off the ventilator more quickly. There's mortality benefit for ward patients, and you prevent them from going to the ventilator. As mentioned, there's no benefit and suggestion of harm for individuals who are not on oxygen, so don't use this for your outpatients. You treat 35 people and you stop one person from dying, so pretty effective therapy. It's 6 milligrams a day for 10 days, given either IV or orally, and it is dirt cheap. Next slide, please. So, of course, inhibiting viral replication is a pillar of COVID therapy, and remdesivir was investigated again early on in the pandemic to see if perhaps it would work. This was a meta-analysis done in 2021, which is a million years ago, of course, but it still, I think, holds true today. Two largest trials looking at it at that time were the Solidarity trial and the Act 1 trial. And those two trials showed very similar things. In individuals who were relatively early on in their disease course, so within 10 days of illness onset, and assuming they were on low flow oxygen, not high flow oxygen, remdesivir reduced the chance of death numerically, not statistically, but although the 95% confidence interval was very suggestive at 0.8 with a confidence 0.63 to 1.01, so just passing the line of unity, but very suggestive, of course. Interestingly, when patients were in high flow oxygen or ventilated, there was no benefit. And perhaps that's because at that point in the illness, the immune response needs to be the focus of treatment rather than on viral replication. It's further on, the viral response is less relevant. Next slide, please. So how does remdesivir work? It's a nucleoside analog, so it gets into reverse transcriptase of the virus itself, but the next nucleoside can't be attached to it, so it stops viral replication. It doesn't seem to work in those who are critically unwell, as mentioned, high flow oxygen or ventilated. there is a benefit for mortality, although it touches the line of unity. There's no significant toxicity to it. The number needed to treat is 143 to prevent a single death. It's given IV only, which is a challenge, of course, but for these hospitalized patients, they typically all have IVs anyways. It's 200 milligrams once and then 100 milligrams for the subsequent 4 days, and it costs about $3,000 for 5 days. Next slide, please. So in patients who deteriorate despite dexamethasone use, again, the question becomes, geez, what do we do? Excuse me. So, well, we use more potent immune suppressants. And so there are two options in this situation. One is Tosalismab, and the other is baricitinib or other JAK2 inhibitors. And so we'll talk about Tosalismab first. So this is a study, again, published in 2021, but it's, I think, the largest study on Tosi. And it demonstrated that in individuals who have very high CRPs, who are critically unwell with COVID, either on high flow oxygen, intubated, ventilated, or deteriorating on dexamethasone, that these individuals died less if they were given Tosalismab instead of standard of care at the time, which was nothing further. Next slide, please. So it's an anti-IL-6 antibody, and that's how it reduces the cytokine storm that COVID has been shown to induce. The largest study I just demonstrated showed a reduction in death and the need for escalation of care to mechanical ventilation. Those already on high flow therapy. It reduced the need for dialysis, again, probably because of less systemic inflammatory response. Given 25 people, you saw one person from dying, but 25 people in that category of already deteriorating despite best care already being dexamethasone. You give it 8 mg per kg IV times 1, and it costs $1,000. The issue was, next slide, please, is that when Delta and subsequent variants were going around, in a population that hadn't yet been vaccinated or exposed, we were dishing out a lot of Tosalismab, and there were critical drug shortages. And Tosalismab is actually an important drug in the cancer space, where it can be used it can be used for patients who are having reactions to CAR T cell therapy. And so we can't let that drug run out, because in that situation it can also be life-saving. So when Tosalismab supplies were getting low, we were looking to alternative immune suppressions, and JAK inhibition was investigated, baricitinib in particular, and it was found to have a similar efficacy endpoint as Tosalismab. Next slide, please. Now, the data for baricitinib isn't perhaps as strong as Tosalismab, and so IL-6 inhibition remains preferable when that drug is available, which I think is pretty, which I don't think is a problem at this point any longer. But like Tosalismab, baricitinib reduces cytokine storm, and it may or may not have some direct antiviral effects. You treat 33 people and you prevent 1 death. It's given 4 milligrams daily for 14 days, or if the patient is discharged sooner, it can be stopped at that point, and a similar cost as Tosalismab. We don't combine the use of Tosalismab with baricitinib, and so you use Tosalismab as first line, and if there are drug shortages, you can use baricitinib instead. Next slide, please. Couldn't talk about COVID-19, especially from a Thrombosis Canada perspective, without at least mentioning venous thromboembolic disease. These numbers may be a little bit outdated now, just because, again, the cytokine storm associated with COVID-19 is much less. Although patients admitted to hospital, particularly in the ICU with COVID pneumonia, these numbers probably do still hold. So the rates of ET and COVID-19 outpatients is relatively low, less than 1%. For ward inpatients, less than 5%. But for ICU inpatients, quite a bit higher, in the range of 5 to 10%. And so, next slide, that raised questions regarding, well, should we be thinking about using anticoagulation to help treat these patients and prevent VTE? So there were several drugs that were looked at, several studies that were done. Next slide, please. And what was found was that in individuals who are hospitalized but not critically unwell, meaning they're on low flow oxygen, so oxygen by nasal cannula, they seem to benefit with therapeutic anticoagulation with a low molecular weight heparin molecule. So VTE prophylaxis, but with therapeutic doses of the anticoagulant. However, interestingly, when patients were critically unwell, either in the ICU or in high flow oxygen, therapeutic anticoagulation didn't seem to work, didn't seem to prevent COVID-related oxygenation issues, but it did cause more bleeding. And so, so thus the current recommendations are in individuals who are hospitalized with COVID-19 and are on oxygen, but not on high flow oxygen, they should probably receive therapeutic anticoagulation for a period of 14 days and then prophylactic after that. And if the individual is in the ICU, to simply receive prophylactic anticoagulation. Next slide, please. And so with that, I'm going to hand over to Dr. Castellucci for post-hospitalization care. Thanks very much.
Thank you, Ben. Next slide, please. So those are my disclosures. Next slide, please. And we'll continue with our patient that we discussed earlier. So Mr. D, who unfortunately returned back to the emergency department despite a trial of outpatient therapy. And he was admitted to hospital, and he's now improved to the point that he's ready for discharge home. And he's received several of the therapies that Ben discussed in his presentation. And we need to decide on whether or not some of these should be continued or if they're only for in-hospital therapy. So we'll go through each of these treatments and discuss what to do with them. Next slide, please. So as we heard, all hypoxic patients benefit from receiving dexamethasone, and in particular for moderately ill patients requiring oxygen, we use it for a maximum of 10 days at 6 milligrams per day. Next, please. What we do with this at the time of hospital discharge depends on a couple of things. If he's being discharged without supplemental oxygen, then you stop the dexamethasone at the time that he's being discharged home. Next, please. If, however, he does require supplemental oxygen as a means to try to expedite discharge from hospital, for example, if there are concerns with overcapacity, or if perhaps he's just been very slow to wean from oxygen, it is an option to continue a 10-day course of dexamethasone. The other thing to keep in mind is that earlier in the pandemic, we were seeing patients diagnosed with cryptogenic organizing pneumonia as a complication of the inflammatory process from COVID pneumonia. And some of those patients do benefit from a higher dose of steroids, typically with prednisone. And those are patients that are usually followed by a respirologist as an outpatient. And so they may end up going home on steroids, but at a much slower taper. And so that would be another group of people to consider prescribing steroids at the time of discharge. Next slide, please. If remdesivir is used, as Ben mentioned, it's given for a total of 5 days in hospital only. And so if patients are discharged prior to 5 days and prior to completing their course, then it's discontinued at the time of discharge. Next slide, please. Tosalismab, as we heard, is for patients that are deteriorating in hospital, and it is a one-time dose given in hospital, so it's not used post-discharge. Next slide, please. Now, importantly, we did spend some time hearing about the anticoagulation trials. And as we heard, for patients admitted to the hospital ward that are hypoxic, many patients will benefit from receiving therapeutic dose anticoagulation. And this is given for up to 14 days during the acute illness. And it's discontinued either at the time of hospital discharge or earlier during the hospital stay if a patient stops requiring oxygen. At the time of hospital discharge, anticoagulation is typically stopped unless there's another reason to continue it. And those would be diagnosis of DVT or pulmonary embolism, for example. Next slide, please. Now, as you heard, there are many studies that we learned about regarding anticoagulation anticoagulation use for hospitalized patients. And there are 2 trials that looked at patients post-hospital discharge. Active 4C is led out of the United States, and it was comparing apixaban 2.5 milligrams twice daily to placebo for 30 days after hospital discharge. This trial, while it's still open, it is no longer actively recruiting participants. And when I looked at clinicaltrials.gov earlier this week, it indicated that it's likely to close sometime in August. So I suspect that we will get some information about the patients recruited into the study in some form of publication in the coming months. The other trial that you may have heard of is the Michelle trial, and this was published earlier this year in the Lancet. And this is the only direct oral anticoagulant study looking at rivaroxaban 10 milligrams daily compared to no anticoagulation for 35 days in patients that were admitted to hospital for a couple of days for COVID-19. These are patients that had an elevated D-dimer and an improved risk score of 2 to 3 or 4 or more points. And the improved risk score looks at typical risk factors for VTE and importantly includes a history of VTE. 320 patients were included in this trial, half randomized to rivaroxaban and half to no anticoagulation. And what we saw with the composite primary outcome, which included things like symptomatic VTE, asymptomatic VTE, and the asymptomatic VTE was done with screening ultrasounds as well as screening CT scans looking for pulmonary embolism. And there were also some arterial thrombosis endpoints in there. And what we saw is that in the patient group that received rivaroxaban, there was a reduction in that composite outcome. However, when you look at each individual outcome, the only ones that were statistically significant were the ones related to screening imaging. And because we don't routinely have the ability to do screening CT scans on our patients, I think it's important to look at other reasons why a patient may benefit from post-hospital discharge prophylaxis. And so those would be patients in our practice that may have had history of a provoked DVT or pulmonary embolism, and that would be considered a higher risk patient where you may want to give them several weeks of DVT prophylaxis. Next slide, please. For patients who may have received recombinant antibodies, this is not something that we are routinely using anymore, and so this again would be during hospitalization only. Next slide, please. Before we move on to our questions and answers, I do want to show you the next couple of slides with the information on your next slide, please, which shows our recommendation. As you heard earlier from several of our speakers, there is a drug-drug interaction with the ritonavir component of Paxlovid and direct oral anticoagulants. And it's concerning enough such that what happens is the serum concentration of anticoagulation increases and can put patients at increased risk of bleeding. And because of that, we do have these resources available on the Thrombosis Canada website under the resources tab. And this is a way for you to reference the direct oral anticoagulant that a patient may be taking with the ritonavir, and you can decide on whether or not an intervention needs to be made with respect to the anticoagulant. And as we also mentioned, we do have a link to the Ontario Science Table pathway that again gives a bit more guidance as to what anticoagulant could be used in place of one where there is a strong drug-to-drug interaction. And now I'll hand it back over to Dr. Douketis.
Thank you very much, Dr. Castellucci, and indeed, thank you to all the speakers for really tour de force presentations that were both very practical and up to date. So I want to remind the audience that you can send in your questions to us through the chat line. And I'll get the ball rolling by maybe asking Alan and Dominik about post-Paxlovid rebound. Is this something, Alan, that you've seen in patients in your practice? Do you think it's common? And maybe Dominik, you know, if the patient presents with these symptoms, should we do anything different than asking them to isolate? Are there treatment options? So Alan and Dominik, what do you think? What are your thoughts about post-Paxlovid rebound?
Okay, so I'll start off by saying, hopefully Dominik can talk a little bit more about this than I can. I personally have not had I've not seen it. I've not had an issue with it. But then again, I've got a highly vaccinated population. My patients are, routine family medicine patients. There are a few on who are immunosuppressed who require treatment. I've certainly got some elderlies who require treatment with comorbidities. But for the most part, I don't find I need the drug a whole heck of a lot. So that's probably the reason that I have very little experience with it. So I'll turn it over to Dominik.
Good question. I mean, it's been all over the media, and I think Fauci had rebound or reported to have rebound, which made it a very attractive topic in the media. There's one study I saw that reports a few percent of all cases with rebound. Typically, I've seen less than 1%. In the published literature, which explains that probably none of us would have seen this, or certainly not more than once, because it's relatively rare. We need to remind ourselves, why are we giving Paxlovid to patients? We give it to them to prevent progression to severe disease. If there is rebound, it's typically mild disease. So Paxlovid still does its job, but you prolong the mild symptoms, I would say. That's what we see with those rebound scenarios. There's one study that looked at, well, what patient population is that? And they found it's not a resistance issue, so it's not that the virus would become resistant against Paxlovid and that resulting in rebound. It doesn't seem to be due to a lack of immune response. When you test the cellular response in those patients, they show a strong cellular, so T-cell response as well. The assumption that the one set of researchers are making at this point, and again, it's assumptions, we only start to understand this phenomenon, is that it might be individuals who are fast metabolizers who prevent the drug to sort of prevent all viral replication, so that you have some viral replication left after the 5 days, you stop the Paxlovid, and then it again takes a few days until your immune system gets this fully under control. That's why those mild symptoms may rebound. But that's just the working hypothesis, or one working hypothesis at this point. But the main concern that people have had, that it might be development of resistance, that doesn't seem to be the case.
The one thing that I will add is, the vast majority of my patients do not require antiviral therapy. And in those patients, I will not uncommonly see that they tell me they feel better, and then a week later, they're getting symptoms back again. So, I guess the data is perhaps suggesting that there's a difference to the Paxlovid patients, but bottom line, I think, is this bug, like so many other viral respiratory illnesses, goes away and kind of comes back and gives you a second shot. That's been my experience with my patients, many of them anyways.
Thank you very much, Alan and Dominik. We've got a few questions coming in, and while they're coming through the chat line, maybe I can go back to Dominik and kind of lean on you a bit. A lot of patients are receiving Paxlovid. Is there a kind of typical patient in whom, you might think, maybe Paxlovid is not the right drug and I need to refer them to a specialized clinic for remdesivir? What would be a typical phenotype of that patient, Dominik?
Yeah, it's basically those that have concerns in terms of interactions. So a patient on amiodarone, for example, and you cannot and don't want to stop that, then that would be a patient where Paxlovid would be contraindicated. So you would, if they meet the criteria, consider them for remdesivir. It's mostly the interaction piece, as it has been shown in the slide set today. Side effects are not an issue. So far, allergic reactions are not the issue. We probably need to see people who get re-exposed to Paxlovid, but it doesn't seem to be an issue. So in the end, it's the interactions which may push a patient from Paxlovid to remdesivir if they require treatment. And I think what we all observe, given how easy it is to administer someone Paxlovid versus
getting someone into a clinic to give them IV remdesivir, maybe with the exception of what we've heard in Alberta, where it's set up very well, is that, you may then say, I would have given the patient Paxlovid, but they are not as high risk, so maybe we just go with budesonide and leave it with that. So that's certainly probably just a typical reaction once you go to a more complex treatment, but in general, same criteria you would use for remdesivir, but you would fall back to remdesivir if Paxlovid is not an option for a given patient.
Yeah,
Okay.
so briefly, I'll just say from a primary care perspective, the assessment now looks like, first of all, severity of illness, followed by requirement for antiviral therapy. So, I mean, that's the first thing that you do in primary care when patients are calling you with COVID. And I just check that table and I determine whether or not they fit. The next thing is, again, exactly as Dominik said, what are the potential drug interactions? And that's an easy check. I mean, there's lots of places where you can look for the drug interactions. And I do a quick look, but I think the important thing to remember is, although many drugs have, almost all drugs are CYP3A4 metabolized, but it's only drugs with a narrow therapeutic window that you have to worry about. I'm not worried about statins particularly. I'm not worried about antihypertensives or anti-diabetic agents. I'm those that don't cause hypoglycemia. But what I worry about the single most important consideration is direct-acting oral anticoagulants. So, the elderly, as I mentioned earlier, the elderly atrial fibrillation patients, they are probably the most common amongst patients that I have to refer to the hospital for remdesivir, and that's exactly what I do.
Yeah, and just to emphasize how we have the resource on the Thrombosis Canada website that covers all of the potential drug-drug interactions. So there are 3 participants that want to provide some questions, through just verbal communication, and I'm going to start with Dr. Bruce Ritchie.
No, listen, I thought it was a very good talk. One of the questions, and I provided it earlier, was how long should we be treating these people for with anticoagulants once they have a thrombosis? And, people are saying these are provoked clots, and therefore they only need 3 months of treatment. But the coagulation abnormalities that happen with COVID-19 seem to go on for a very long time. So what are your thoughts about that?
Well, maybe Lana and Ben, just quickly for Dr. Ritchie, how long would you treat a COVID-associated clot?
Sure. So, I think the ones diagnosed when a patient is admitted to hospital for COVID infection, I think in my mind, those are clearly provoked, and I treat those for 3 months. For patients now that we are seeing where their severity of illness is such that they're at home and they may be diagnosed with a clot a few weeks after recovering from COVID, I consider those more on the weekly provoked spectrum. And I probably treat those for closer to 6 months rather than 3 months alone, similar to the way you would with another respiratory viral infection that isn't hospitalized. So I think that's how I treat that.
Sure. There's a lot of data, though, that suggests that there's abnormality in platelets and other things that goes on for many, many months after a COVID infection.
Yeah, absolutely. We just don't know how that translates into VTE risk. And that's the part that we're sort of missing that information.
Okay.
Thank you very much, Lana. So we have another question, and forgive me if I mispronounce your name, is from Dr. Colleen Hicks. Dr. Hicks, did you want to share your thought and question with us? Yes, please go ahead.
Okay. I'm a pharmacist, not a doctor, but I had a 78-year-old patient who was treated, multiple comorbidities, treated with Paxlovid for 5 days. She went back to the local COVID clinic because she still had a persistent cough. They didn't give her anything, and they told her, you will be coughing for 6 weeks. And I'm just wondering, is that appropriate? Like, I even faxed the GP and said, can budesonide not be considered for this poor woman?
Well, many patients who get viral upper respiratory tract infections experience post-viral cough syndrome, which can go on to 6 weeks is not unusual. But certainly it can resolve earlier. And in terms of treatment of post-viral cough syndrome, regardless of its origin, whether it's COVID or not, the budesonide doesn't work. I've not found inhaled steroids to be particularly effective.
But I found Symbicort is extremely effective.
Well, my experience has been the opposite. That post-viral cough syndrome goes away when it's ready to go away.
I think you'll find. You'll find a lot of people will swear by Symbicort.
Perhaps.
Okay.
Yeah. I think there's a lot of variability in response, but I think what Dr. Bell is saying, that it's not kind of a standard thing that you're trying to deal with post-viral, injury to the bronchial wall, but, may work in an individual patient. We had another question from a Dr. Vaughn Mallows. Dr. Mallows, did you want to give us your thoughts and question? We have a question from Dr. Mallows in the chat line, and that is their question from Dr. Mallows is what is the absolute benefit of full dose anticoagulation in moderately ill hospitalized patients? The vast majority of these patients in our hospital do not receive full dose anticoagulation, so I'm looking for something to drive full. I can ask Ben about the use of IV heparin in a hospitalized setting, or is that something that we're still considering? And once again, if there's someone who's not muted, please mute your line unless you're speaking. Ben, what do you think about IV heparin nowadays in hospitalized patients?
That's a great question, actually. So perhaps I generalize, rather than saying IV heparin, saying therapeutic anticoagulation for VT prophylaxis in hospitalized patients with COVID-19 pneumonia, and I think that we should be looking at the patient population that was in the biggest trial that looked at this, which I think was the multi-platform RCT. And looking at the patient in front of you and asking yourself, is this patient a patient that would have been in that particular trial? So the multi-platform RCT was done pre-Delta and Delta time. It was done in a largely unvaccinated population who had not been exposed to the virus, and it was done in individuals who, there was no question, had COVID-related pneumonia. And so if you're looking at an individual, so what I would say is that if your patient looks like a multi-platform RCT patient, they have, and probably I'd say if they have what looks to be like COVID-19 pneumonia, then I think, and they're on low flow oxygen, then I think it would be quite reasonable to think about therapeutically anticoagulating that patient. Also, of course, assuming that they don't have, a significant risk for bleeding. And so if you have that patient, if you look at the mortality data, which I'm sharing right now, so an individual who has moderate state COVID pneumonia on low flow oxygen, the mortality rate for patients who got usual care thrombotic prophylaxis, which was predominantly
he's talking about my freaking question.
The mortality rate was 7.7%. Compared to 5.7% in patients who got therapeutically anticoagulated. So that's a 2% absolute risk reduction by therapeutically anticoagulating these patients. And so I think that it should certainly be considered if you think they have COVID-19 related pneumonia and they're on low flow oxygen. If they're on high flow oxygen, they should be switched, I think, to prophylactic doses.
Thank you very much, Eddie. We've reached the end of the presentation this evening. I think we've had a few technical difficulties. If you do have some questions, please send them to Thrombosis Canada, and we will respond to you promptly. We want to remind you that we value your input and want to get your feedback about this presentation. So please take a couple of minutes to complete the evaluation that you have in front of you. We'd also like you to consider supporting Thrombosis Canada for a lot of the activities that we do. Visit our website and see a lot of the resources that we have for healthcare professionals and for patients and family. And finally, I'd like to remind you that we have our annual conference Toronto this coming October 14, 15. So please go to our website and learn more about this. It's a great way to be up to date on areas of thrombosis. And with that, I'd like to thank you very much for attending this evening,
because I missed
and to the faculty for their participation. Once again, please feel free to connect with us by email if you have any additional questions, and we will try to address them promptly. Thank you again, everyone, and have a pleasant evening.